Have a good day, everybody, morning, afternoon, and night in some of the places. So this is the joint session of the SIOP Global Health Network with the Partnership Working Group and the Pediatric Hematology and Oncology chapter of the Indian Academy of Pediatrics. So this is a new program and a new pathway that the Partnership Working Group is envisioned to spot different pediatric hematology and oncology associations around the world. And the first is India, and I'm going to do a presentation about some of these slides, and later we will go from there. Just to inform some of the people that may not be familiar, is that SIOP continental branches, there are 6: Asia, Africa, Europe, Latin America, North America, and Oceania. So there are 9 different networks that they are distributed to different disciplines: nursing, nutrition, global health, women leaders, PPO, supportive care, survivorship, epidemiology and outcomes, young SIOP, and many other working groups in each particular network. Every SIOP member has the opportunity to join each continental branch, depending on your location, networks, and working groups, and obviously receive the benefit of the in-person or online activities like today's webinar. So I am going to transfer now to Dr. Amita Mahajan, who is my co-chair, and she has been working hard to make sure that India will be the first country to participate in this new format. Anita?
Hi, Sisa, and good afternoon to everyone who has joined in from India, and good morning and good evening to everyone else. Again, on behalf of the SIOPS Partnerships Working Group, we extend a warm welcome to all of you. And September being Childhood Cancer Awareness Month, this is a very good opportunity for Partnerships Working Group and SIOP to highlight national pediatric societies. So as Cesar just discussed, we have 2 talks for the day. We are highlighting India, a country with the maximum population and maximum strengths in terms of the numbers of patients that we are seeing, but a lot of challenges, and how over the years cooperative working groups and collaborative trials have helped develop indigenous treatment or adapted treatments for our country. So we have 2 talks today. One is by Dr. Amita Mahajan. Dr. Amita Mahajan is a senior consultant in the Department of Pediatric Hematology Oncology at Indraprastha Apollo Hospitals in New Delhi. And she has been working very closely with Cankids, the NGO, which is the national NGO, which is working for the cause of pediatric cancer patients in our country. And she's going to present her work on a collaborative study of newly diagnosed children with Hodgkin's lymphoma in India. After this, we'll have a talk by Dr. Shekhar Krishnan. Dr. Shekhar Krishnan is senior consultant, again at the Department of Pediatric Hematology Oncology at Tata Medical Center in Kolkata. And he is going to present his work on Indian Childhood Collaborative Leukemia Group Multi-Center National Standardization Study for newly diagnosed ALL. So now I hand over to Dr. Amita Mahajan to discuss her work. Over to you.
Thank you, Dr. Neeta, Dr. Cesar. It's truly a pleasure to be here today and to present our work on behalf of the Hodgkin Lymphoma Working Group. Slides share. I'll just give me a minute to open my slides. Neeta, are my slides visible?
Yes.
Okay. To all our friends from across the world, greetings from India. And once again, I thank you for the privilege of presenting this work on behalf of the Hodgkin Lymphoma Working Group. As Neeta said, as of last year, we are the most populous nation in the world with the largest number of children. It is estimated that every year we have over 4,500 new children with Hodgkin lymphoma in India. The condition itself has been highly curable even in resource-limited settings. But balancing efficacy with long-term toxicity has proven to be an extraordinary challenge, with the standard of care for our setting remaining elusive. This is largely attributable to the wide disparity in access to healthcare in our country, and one could say that there are many Indias within India. In fact, even in the same city, right next to each other, as you can see in the slide. We put a man on the moon last year, but bullock carts remain everyday reality in much of rural India. So in this background, the overriding aim of all work that has been done under the umbrella of Indian Pediatric Hematology Oncology Group is really to eliminate the disparity in outcomes. With WHO Cure for All initiative identifying Hodgkin lymphoma as an index cancer, all stakeholders in India are committed to ensuring universal access to treatment and optimizing outcomes for each individual child with Hodgkin lymphoma. For the next few minutes, I'd like to share a little bit of what we have known for some years of Hodgkin lymphoma in India, the more recent INPHOG experience, and the steps that we have planned for the next few years. Prior to the initiation of the first study, the INPHOG HL 1501, a systematic survey of 13 studies covering more than 1,700 patients reiterated that by and large ABVD was the commonest regimen used across the country, with reasonably good outcomes. The vast majority of disease was EBV driven, with its predilection for the younger male child. Despite being a relatively simple protocol, abandonment was still a significant issue. Risk stratification and response adaptation were not practiced widely, and this is, I'm talking about 2015, before this study was initiated, with all patients receiving 6 and sometimes even 8 cycles. Radiation was delivered very variably depending on access to this modality and the treatment philosophy of the individual treating unit. Data on late effects was limited, as was the experience with alternative, what would be called standard of care regimen, and much of that experience was from single center retrospective studies from academic institutions. I'd like to share a couple of those, the results of those studies with you. This study from a tertiary referral center in North India used OEPA-based, or what we could call as the standard of care treatment, and PET-based strategy for pediatric Hodgkin lymphoma. The results were acceptable and comparable to the rest of the world, but what was striking was treatment abandonment of 9% and a treatment-related mortality of about 5%. That was worrying for us. Another study from a large center in Mumbai again showed excellent outcomes with this strategy, but 80% of the entire cohort received radiation, and a non-relapse mortality of 4% was again concerning for us. Work, multi-centric prospective collaborative work in India truly began under 2015 under the umbrella of the Indian Pediatric Hematology Oncology Group, with all of our oncology colleagues coming together. And one of the first efforts from this initiative was the INPHOG HL 1501 study. The study employed a simple risk-stratified response-adaptive treatment algorithm on an ABVD backbone. Radiation was limited to sites of bulky disease and diagnosis, and those with inadequate response at early response assessment. Response assessment, for response assessment, PET-CT was strongly recommended but was not made mandatory because limited access to this modality at the time of initiation of this study. The key goals of this study and effort were to limit treatment burden for patients with early stage disease, to optimize outcomes for those with advanced stage disease, and to develop a collaborative network which we hope will form a springboard for prospective collaborative work in the future. This slide shows the schema, the simple schema of this study. All patients received 2 cycles of ABVD followed by either PET-based or conventional imaging-based assessment. Patients with early stage non-bulky disease received 4 cycles of chemotherapy subject to satisfactory response. Patients with advanced stage disease received 6 cycles of chemotherapy, ABVD-based chemotherapy. All patients with bulky disease and those with inadequate response at the early response assessment point were asked to proceed to radiation at the end of treatment. This is the schema for advanced stage. This being the first effort in its own way faced many challenges from the ethical committees at various institutions grappling with the concept of an investigator-initiated multicentric study with no formal funding. Other challenges were having to translate our information sheets and inform consents in multiple languages for the multilingual country that we are. Regardless of these challenges and overcoming these challenges, 27 centers participated in this study, which was the first in its. The key findings from this study were as follows. A total of 410 patients were enrolled over a 3-year period, 396 of whom had complete data for analysis. The median age of this cohort was strikingly younger from that reported in Western cohorts, and again with a striking male predisposition. We feel that this is not just due to gender bias, it is primarily attributable to the EBV-driven biology of Hodgkin lymphoma in our country. 2/3 of patients had advanced disease, and nearly half of the patients had B symptoms and bulky disease. Not unusual or unexpected for our country, about a third had received empirical anti-tubercular therapy prior to the initiation of this study. Surprisingly for us, despite being our first effort, protocol violations and treatment delays were minimal, perhaps owing to the simple study design. 40% of patients with early disease and 45% of patients with advanced disease received radiation. Abandonment could be limited to under 5%, and that is the lowest reported from any of a similar cohort studies in our country. We had 2 deaths during the course of this study, both non-neutropenic, one owing to varicella myocarditis and the other owing to severe acute gastroenteritis, which continues to be a major killer in India, even for non-immunocompromised children. At a median of 52 months from diagnosis, the estimated 5-year event-free and overall survival for patients with early stage disease were 95 and 97% respectively. For advanced stage disease, the event-free and overall survival at this point of analysis were 80 and over 90%. On multivariate analysis, the only statistically significant predictor of event-free survival for advanced stage disease was use of radiation, as you can see in the Kaplan-Meier curve depicted in this slide. And that means that with ABVD, if we are to achieve optimal outcomes for advanced stage disease, we may need to add radiation for a significant proportion of our patients. As expected, patients with B symptoms had inferior outcomes, but bulk at diagnosis did not impact outcome, primarily because the treatment was stratified for bulky disease. Again, similar to many other studies, patients with low albumin and hemoglobin at the time of diagnosis had inferior outcomes. A CHIP score may be irrelevant, the CHIP prognostic score that was frequently used in adults and has been validated in children as well, may really not have a place in the current era of PET-based response-adapted treatment. But for our setting, we could use it to identify a cohort of patients with markedly inferior outcomes, and if we can identify this cohort at diagnosis, perhaps more intensive strategies for this group can be employed at the outset wherever feasible. As earlier said, our cohort was much younger, but 9% was actually less than 5 years of age, with an even more striking male predominance of 34:1, as you can see in this slide. They were less likely to have bulky this bulky disease, mediastinal disease, or splenic involvement, and outcomes were at least as favorable as those for older children. But it highlighted to us that we need to very carefully plan our future treatment strategies because many of our patients will be very young, and even there is an even larger need to avoid radiation in these patients. Like I said earlier, 29% had received empirical antitubercular treatment prior to initiation, prior to the definitive diagnosis. This group was more likely to present with advanced stage and weak symptoms, more likely to have infradiaphragmatic involvement, but had similar outcomes. However, presenting with more advanced stage disease meant that they received more intensive treatment. We attempted to look at whether PET-CT or CT-based modality impacted on our use of radiation. And in fact, we could find that there was a significantly higher chance of allocation to the RT arm, if almost twice as high if you had CT-based response evaluation. The outcomes were similar for the two cohorts, but the CT-based cohort and more of the patients ended up receiving radiation. This simple analysis has helped us to convince support groups, hospitals, and colleagues for PET-based staging and reassessment, with the argument that that will help us avoid radiation in a significant portion of our patients. The study core team had committed that all patients would be followed up till 5 years from last enrollment. And at this time point, which was about a year ago in 2023, 368 of the 396 patients we could track and had the complete data. And in summary, the 6-year EFS and OS or the final result for patients with early disease was 93 and 95%, and for advanced stage disease, 75 and 89.6% respectively. We could conclude from this study that the strategy employed is non-inferior to more intensive treatment for patients with early stage disease. It is suboptimal for patients with advanced disease, and perhaps for those patients, wherever feasible, more intensive treatments could be employed. Very, fortunately for us, no patient has reported a second malignancy in the 8 years or 9 years now from the initiation of this study. So this is the Kaplan-Meier curves for the final analysis with 6-year survival. We have other challenges. So we may achieve reasonable outcomes regardless of what strategy we use. But issues like fertility preservation, they are being neglected. So in this cohort, only 7 patients were actually offered fertility preservation, and only 2 patients could actually go ahead and achieve sperm preservation. While we were reaching the end of this study, it became clear to us that we will also have to develop our own protocol for relapsed refractory patients as they were emerging from this cohort and from our, other centers across the country. We need to look at this for our setting because of the limited access to stem cell transplant for a large number of patients. There is also increasing evidence that a subset with low-risk disease may do equally well with conventional salvage chemotherapy or immunotherapy and radiation and may not actually warrant a stem cell transplant. Therefore, a study was planned with a risk-stratified response-based algorithm using gemcitabine as first salvage chemotherapy, due of its low toxicity and efficacy comparable to other regimens. Patients with primary refractory disease, early relapse, symptoms, relapse in an irradiated site, extranodal or stage 4 disease were allocated to the high-risk arm and asked to proceed to stem cell or offer stem cell transplant at the end of chemotherapy or achieving complete metabolic response. Patients with none of these high-risk factors were allocated to the low-risk arm and received chemo and radiation only. This is the treatment schema of this study. Patients who did not achieve adequate response to gemcitabine after 2 cycles were offered ICE chemotherapy. A total of 70 patients were enrolled from 9 centers with a median age of 12.5 years, with a similar male to female ratio that we have seen in the frontline study. 2/3 of these patients were in the high-risk cohort. The key results from this study and long-term follow-up is ongoing. showed us that with gemcitabine we could achieve complete metabolic or partial response in 71% patients. For patients who had alternative protocols, which was about 20% of this cohort, also had equivalent chances of complete metabolic or partial response. PMR could be achieved in only 37.5%. Only 2 of the 12 patients switched to ICE chemotherapy achieved complete metabolic response, conveying to us that you're either chemosensitive or not, and normal treatments may be more prudent for this cohort rather than switching to more intensive chemotherapy. 51 patients of this cohort were eligible for stem cell transplant, but only 15 could undergo the procedure, again highlighting the limited access to this modality in our country, which was further aggravated due to the COVID pandemic, and that was the time period this study was conducted. This is at the median follow-up of 26 months. The overall survival and event-free survival of this cohort is 80 and 70%. At the same time, we'd identified that the high risk group or advanced stages, this is not, ABVD may not be the optimal regimen, but we were concerned about omitting radiation for bulky disease in this cohort. So our colleagues at the Tata Memorial Hospital have initiated this study, which is currently ongoing, which is specifically looking at the feasibility of elimination of radiation in patients with bulky disease who have achieved adequate response on PET-CT after 2 cycles of wave-up. The risk stratification in this study is much more refined, and we have been able to move to a central review of PET-CT for accurate staging, bulk assessment, and response evaluation. The study is ongoing and has a target recruitment of 700 to be completed over 5 years. We also were very cognizant of the fact that for relapsed refractory cohort, a number of our colleagues are using various combinations of chemoimmunotherapy with a combination of low-dose nivolumab and bendamustine, getting the maximum interest and achieving good responses. We therefore have just recently rolled out this study, which is attempting to look at the real-world data of the use of immunotherapy in children and adolescents with Hodgkin lymphoma, and most of these are actually in the relapsed refractory cohort. We feel that the study may be able to give us a regimen that is ideal for our setting and our challenge. What do we hope to achieve in the coming years? We have a number of topics that we are currently debating and working on. ABVD continues to be the most commonly used treatment strategy, and we would definitely be interested in looking at the omission of RT on PET-CT based evaluation, which has not been evaluated in the context of ABVD. It's very valid for our country with the young cohort that we are dealing with. We're also contemplating looking at elimination of bleomycin, as has been evaluated in adult cohorts for early stage patients with good response. We also hope to hopefully look at prospectively on the combination of low-dose nivolumab and bendamustine for the relapsed refractory Hodgkin lymphoma. And hopefully we would now be able to focus a bit more on the late effects, which we have not been able to do. Summary, regardless of therapeutic strategies, even in our setting with our challenges, most children with early stage Hodgkin lymphoma will be cured. Wherever feasible, we can try to optimize treatment for patients with advanced stage relapsed refractory disease, while continue focus on strategies which limit the price of cure. For a number of years, we felt a bit defensive and inadequate when we are using modified or indigenous protocol. This experience with Hodgkin lymphoma, and indeed this editorial comment in response to one of the papers published from this study, has reassured us that there can be more than one standard of care dictated by logistics, resources, and perhaps patient-reported outcomes. Our challenges, the challenges of low middle income countries are unique, and we will have to work to try to find the solutions ourselves. I acknowledge the participation of all centers The patients and families and the red dots depict the centers that have participated in one or more of these studies. Cankids, the National Society for Change for Childhood Cancer, that has been the principal sponsor for 3 of these studies, the National Cancer Grid, which is supporting one ongoing study. Dr. Monica Minsel and Dr. Peter Cole, who vetted our frontline and relapse protocols and steered us in the right direction. Thank you so much for your time and attention. And I just want, in my background is a glimpse of what Delhi looks like in September. So behind me is what Delhi looks like in September, and I just wanted, because the spotlight was on India, I just wanted you to at least have a glimpse of Delhi. That's India Gate, one of the most important landmarks of Delhi. Thank you so much.
Thank you, Dr. Mahajan, for that discussion on the trial and how, and especially on the way it has evolved and how a small project then evolved into much bigger. And now most of us are actually going back and seeing this data to decide how to manage our patients. And I'm sure a lot of learnings from the study. So there are a lot of questions and few comments as well. I think we'll keep it towards the end, as there is a session we have kept for the question answer session, and we'll take the questions there. And we'll proceed with the next talk. And before we proceed, there are some housekeeping announcements from SIOP, which I wanted to share. So before we go on to Dr. Shekhar Krishnan's talk. So yes, I'm sure all of you who have joined here know SIOP. And SIOP is like this wonderful organization, this umbrella body that brings together all professionals working for children with cancer. So if you are not yet a member of SIOP, please do join. This is not just for medical doctors, it's for radiation oncologists, it's for pediatric surgeons who are treating children with cancer, it's for nurses. There is something for everybody, for physiatrists, for rehabilitation specialists, for nutritionists, for supportive care doctors, everything, for everybody who is part of a team. SIOP is always there. And as a special as a discount of 25% is being offered by SIOP for everyone who is joined for this session today. So for all the webinar attendees today, the email which has been provided at the time of registration, SIOP is recording it, and that discount code will be emailed to you by the SIOP, the admin, for SIOP membership, which is offering a discounted rate for the next 2 weeks. It starts from October 1. So if you have friends who are interested or working in the field of childhood cancer, do ask them to join and avail this benefit as well. And it applies to purchases of 1 year or 2 year SIOP memberships when paying by credit card online. And so now and again, one more announcement regarding the meeting at Honolulu, which is going to be there next month, which is between October 17 and 20. So if those of you have registered, wonderful at meeting, as in it'll a very big platform to meet everyone across the world who are managing children with cancer. So if you register before September 24th, there are again, the Congress rates are much lesser than it will be after that. And all members will have free access to the videos of these of the talks, which will be there till 3 months after the Congress. So do avail that even if you're not visiting in person. So I'll stop share here, and I would welcome Dr. Shekhar Krishnan for his talk on childhood ALL protocol, which was developed in the country. Over to you, Dr. Krishnan.
Thank you very much. I'm just going to share my slide. I seem to have a connectivity problem. I do apologize. So what I'm going to do is I'm going to briefly turn on my video, and then I'm going to close it down and then just proceed with my slides in a moment. Yeah, I trust you're able to see my slides.
Yes, we can.
Thank you.
But I think this is not your first slide.
No,
Yes.
it's not. Okay,
Yes.
so yeah, so thank you everyone thank you to the SIOP Organizing Committee for this opportunity to present on behalf of the Indian Collaborative Childhood Leukemia Group. It is a privilege and an honor to be able to present this work as collaborative grouping. And in the next 20-25 minutes or so, I will try to narrate the journey and the motivation and where we are heading. So the motivation, so I will draw your attention to the table above. And the motivation for this particular work came from the observation of continuing unsatisfactory outcomes over a period of 2 decades at centers which are apex referral centers for management of pediatric cancer. So if you look in the above protocol, MCP 841, at 3 centers, between a period of 1990 to 1997, you can observe in the EFS, the 4-year EFS is 43 to 60%, and you can see the variability between centers. And one of the important limitations for outcomes was mortality, treatment-related mortality. 20 years later, at another premier center where a more contemporary protocol was administered, risk-adapted protocol was administered, again, the mortality was a limiting factor and requiring adaptations to the protocol. But even then it remained high, and you can compare those outcomes with that in multi-country collaborative studies below, North America, Europe, UK, and Southeast Asia, where the mortality is 10-fold lower, 2 to 3%. So one of the important limitations to seeing durable remissions in our patients is the treatment-related mortality. So a concerted effort by centers across the country resulted in this initiative called the Indian Collaborative Childhood Leukemia Study Group, which I will now call as ICICL. And the hypothesis was that risk-stratified treatment based on ALL genetics and minimal residual disease monitoring will allow de-intensification of therapy in patients with low-risk disease and intensification of therapy in patients with high-risk disease, and collectively decrease treatment-related toxicity, improve cure rates, and therefore improve patient outcomes. And to achieve this, there were 4 activities that needed to be done. One is coming together in a multi-center collaborative working partnership, standardized risk stratification diagnostics, high-quality longitudinal data, and uniform protocol-based treatment. So I should now narrate each of these points in stepwise. So the ICICL protocols were developed. The idea actually germinated in 2012 to 2013. And between 2013 and the initial preparatory steps required forming the collaborative group, writing the protocol, and developing the lab strategies. Between 2013 to 2018, we had an observational phase where the collaborative practice and the feasibility of being able to enroll patients, monitor, and follow up was reported by individual centers. Diagnostics were strengthened. A database was being developed for a randomized trial, and funding was being applied for. There was an overlap. In 2016, the randomized trial kicked off. And in this particular initiative, there was additional data capture in terms of toxicity and also good clinical practice adherence monitoring. And this is the collaborative grouping that, as you can see here, there are 5 centers, 2 in the north, 1 each in the west, east, and south. And investigators and laboratory leads contributed to the management of patients and the laboratory diagnostics respectively. And there was a coordinating clinical research unit and, very importantly, a backbone remote data capture system, which allowed high-quality data capture, especially for the randomized trial. And at the 4 ends, you can see the pillars of this work, including the institutional review boards of each center, study monitoring to ensure compliance with GCP practice for clinical research, an independent data and safety monitoring committee for the randomized trial, and funding agencies that allowed individual centers to implement the randomized protocol. Just a very quick screenshot of the remote data capture system, which is individual centers are able to access it, and this allows electronic case report forms, capturing protocol treatment, risk stratification, eligibility of patients. Randomization is also incorporated as one of the working elements in this database. Some basic decision supports in terms of who are eligible and what risk group they should be placed in, and notifications to the various treatment centers regarding enrollment, randomization, serious adverse events, and completion of treatment. I'm now going to talk about our strategy for risk stratified treatment using genetics in minimal residual disease monitoring. So this is the overall how the protocol, how patients were risk stratified. Patients with TALL were given uniformly treated with high intensity treatment that includes patients with lymphoblastic lymphoma, B lineage ALL patients, which I shall now refer to as BCP ALL or B cell precursor ALL, were stratified based on initial poor risk characteristics of patients with CNS disease or high risk genetics, or patients who displayed poor treatment response, which I shall explain in the later slide, were high risk B lineage. Those with NCI high risk, for those of you who are not familiar, NCI high risk refers to patients with either age more than or equal to 10 years or a white cell count presentation, highest presentation count of more than 50 times 10 power 9 per liter, or patients with bulky disease. This was some definition peculiar for this protocol, patients with liver or spleen at or above or beyond the umbilicus, large peripheral nodes, 5 centimeters or more in diameter, or bulky internal lymph nodes. So patients with either of these were intermediate risk, and patients with none of these were B lineage. So it's a dynamic risk stratification with some initial risk stratification, initial presentation, and a second risk stratification based on response. So it was a provisional and a final risk stratification. A talk about the genetics we used. So in order to define genetics in this protocol, if you look at the right-hand side, this protocol actually the genetic strategy was to identify patients with high-risk disease, and for patients with non-high-risk disease, the rest of the treatment was based on patient presentation characteristics and treatment response. So in order to identify high-risk disease, if you look on your left-hand side, you would see that we used a combination of fluorescence in situ hybridization probe using initially 3 and later 4 probe panel, 2 fusion probes and 2 break-apart probes for KMT2A rearrangement and TCF3 rearrangements. And aneuploidy, specifically hypodiploidy, was identified through flow cytometry. And in certain select centers, karyotyping and additional targeted or directed testing for other genetic abnormalities were done based on specific criteria. But the top panel on the left-hand side is the basic genetic strategy. Treatment response, as I mentioned before, TALL patients' treatment response was did not influence risk stratification. So TALL was uniform intensity treatment. B-cell precursor ALL patients were stratified based on poor prednisolone response. So all patients were given a prednisolone prephase for 7 days without any intrathecal treatment. So just 60 milligram per square meter per day, a minimum of 210 milligram per square meter over 7 days of treatment. Response assessed by testing peripheral blood and looking for circulating blasts. At the end of 5 weeks of induction chemotherapy, patients had a bone marrow test, and morphology was, along with clinical assessment, morphological assessment of blast count, SPELT was used to determine remission, and high risk or poor treatment response in terms of minimal residual disease monitoring was based on the estimation of using flow cytometry monitoring for either an 8 to 10 panel, 1 to 2 million events, and this was also evolved over the course of treatment. The threshold for saying MRD positive was 0.01%, i.e. detecting 1 blast cell in a background of 10,000 cells. Withdrawn from protocol, as you can see below. Now, this may be a bit daunting for you, but just very quickly, the treatment protocol was divided into 2 broad groups: intensive treatment phase and maintenance phase. The intensive treatment phase comprised of 4 blocks of treatment: induction, consolidation, interim maintenance, and delayed intensification, running over a cumulative 24 to 27 weeks, followed by a maintenance treatment for 96 weeks, or close to 2 years. As you can see, patients with B standard risk, intermediate risk, and high risk received varying intensities of treatment during induction, consolidation, and interim maintenance. Treatment intensity was similar by delayed intensification and maintenance phases. What you can observe is that patients in induction received, patients with intermediate risk and high risk were exposed to daunorubicin, 2 doses for intermediate risk and 4 doses in high-risk patients. Additional doses of asparaginase in induction as well. Dexamethasone was introduced in a pulsed schedule for patients with TALL. During consolidation, cyclophosphamide cytarabine was introduced as a protocol 1B, BFM protocol 1B, and additional doses of asparaginase and vincristine were given in high-risk patients and TALL patients. Interim maintenance patients were exposed to escalating intravenous methotrexate if they were intermediate risk, and to high-dose methotrexate in gram doses with folinic acid rescue if they were high-risk or TALL. The maintenance phase essentially was only the antimetabolites 6-MP and MTX with intrathecal methotrexate without any vincristine prednisolone pulses. This is just capturing this, and I won't belabor the point. I will draw your attention to the top row, which talks about induction corticosteroid. Patients had a prednisolone pre-phase, as I mentioned, and older children had a prednisolone pulse, which is, that means 1 out of the 4 weeks and taper, 1 week was omitted. And I'll draw your attention down to the bottom 2 rows. CNS-directed treatment was largely intrathecal treatment. Cranial radiation was reserved for patients with CNS3 disease alone. And randomization in the randomized trial was looking at short and long prednisolone in induction and delayed intensification. 1 dose of mitoxantrone was at 3 doses of doxorubicin. I will not discuss the randomization outcomes in this presentation. Now, I'll talk to you about some of the trial patient characteristics in the next 3 slides. As I mentioned before, the patients can be divided into 2 groups. 2013 to 2018 was the observational study, 2016 to 2022, which is the randomized trial. And you can see roughly about 5,000, slightly more than 5,000 patients enrolled in the trials. The TALL proportion is probably better represented in the randomized trials, about 1 in 6. And you can see the age, older patients, not unexpectedly older patients in T compared to B, but the median age was 5 years. As strikingly, and this is consistent observation, boys outnumbered girls 2:1. High presentation counts in TALL, not surprising. About a quarter of patients with bulky disease, NCI high risk in about 40% of patients, CNS disease in about 2%, and high risk cytogenetics in about 10% of patients. It seems a bit daunting, but this is how patients with B-cell precursor ALL flow through the day 8 prednisone response and the MRD assessment at the end of induction. So just place your eye on the left-hand side. Prednisone response was poor in about 1/6 of patients. And combining their presentation characteristics and prednisone response, patients were provisionally stratified as standard, intermediate, or high risk. And what you can see is about roughly in the observational study, about 1/3 were in each group, 1/3, 1/3, 1/3. And this was slightly different in the randomized trial, 40, 34, 26. Following end of induction MRD assessment, about a quarter of patients were reassigned as high risk. And if I draw your attention to the right-hand side, you can see this roughly in the observational study, roughly about 14% of patients were re-stratified as high risk, were previously SR or IR patients, and in the randomized trial, about 20%. So ultimately, in the final analysis, we had about roughly slightly close to about a quarter of patients in provisional standard risk and final standard risk and intermediate risk, and about 50% of patients as final high risk. I just want to make a point here and draw your attention to the middle part, showing that the centers were able to retain patients with low rates of treatment abandonment, 3 to 4%. Another thing which is heartening for us is that we were able to, at least 95% of patients eligible patients participated in the first randomization. The second randomization, it was lower, it's about 3/4, and that's mainly because of the non-availability of the experimental drug, which was in this case mitoxantrone. I'm not going to talk about the outcomes of this study. The most striking outcome was that over the course of over 10 years of implementation of the protocol, initially as an observational study and a randomized trial, there was a striking decrease in mortality. You may recall that earlier, when we started, we were looking at about 15% as the reference mortality. In the observational study, it was a marginal drop, but it was significantly lower, 7.5%, and we hope that this will continue to drop. Induction contributes to the major component of mortality, and that's true between both trials. A big difference between the randomized trial and the observational trial, the drop in mortality during the maintenance phase. And bulk of these deaths were septic deaths, especially gram-negative bacterial deaths. And this is captured here in the cumulative incidence plot, which says the same thing, 10% in the observational study, about 8.5% in the randomized trial. And you can see the trajectory of the curves steeply in induction and then still continuing to rise. And if you follow the red curve, still continue to rise during the induction phase and a bit more plateauing in the randomized trial. The other important thing is what is the impact of risk stratification on treatment-related death. And what you can see, and just draw your attention to the arrows, what you are able to see is that this risk stratification was particularly protective. So de-intensified therapy, patients with B standard risk ALL experienced lowest treatment-related death rates compared to the other risk groups. So the other important point is that whether you receive 2 donors or 4 donor doxorubicin doses doesn't really make a difference. So exposure to doxorubicin is a risk factor for mortality. In the post-induction, once in the remission phase, actually there was no effect of risk stratification on the risk of treatment-related death. So in this particular slide, I wanted, this is, sorry, I missed a moment, yeah. A lot of data points. So just concentrate on the left-hand side, and on the left-hand side, which shows the curves and the line plots. And the table on the right-hand side actually is the numerical readout of that. So essentially it's the same thing. So if you look at the, if you look in induction, consolidation, interim maintenance, delay intensification on the x-axis, what you can see is that the highest rates of highest toxicities were in induction for all risk groups. And this is especially so in the 3 risk groups, the 3 non-standard risk groups who were exposed to anthracyclines. And that comes down during consolidation, and they follow, they are cluster together. And then what you can see is that the intermediate risk patients, the blue line, actually separate out from the rest of the group, because these are the patients who are exposed to escalating intravenous methotrexate without folinic acid rescue, and they experience oral mucositis. And then, as you can see in consolidation, in the delayed intensification phase, the toxicities of most of the groups come together. I just want to draw your attention to the green line, which is the standard risk patients. These patients have the lowest rates of toxicity in induction, but still not trivial. It's 50%, comes down during consolidation and interim maintenance, but again becomes similar to that of induction. 50% of patients at delayed intensification when they are for the first time being exposed to genotoxic drugs, which is anthracycline and cyclophosphamide. And that point is captured here, where you look at the proportion of patients experiencing toxicity. What you can see here is the B standard risk patients, 50% of them have toxicity in this phase compared to the other risk groups. And if you draw your attention to the left-hand side, of the right-hand side, what you can see is that these are the younger patients. So there is an association. We seem to see a consistent association between toxicity experience and age. And what we are seeing is that the younger the age, the higher the risk of toxicity, especially when exposed to DNA damaging drugs. This is a single center study which is reported and showing that, again, risk stratified treatment allows patients, decreases treatment costs. And you can see this in the blue point, is in US dollars. As you go from standard to TALL patients, the cost of treatment increases, not just because of inpatient chemotherapy for high-dose methotrexate treatment, but also for management of toxicities. Now, what about the impact of risk stratified treatment on remission rates? So if you look at this event-free survival curve, there are BSR is in green, BIR and TAL are in blue and gray respectively, and BHR is in red. When we started the ICICL protocol, we said one of our targets was to have outcomes of 80, 70, 60, and 60. And one may take some satisfaction of hitting those targets, but I think we would say that this is cold comfort for us. I would say that I think having experienced and lived through this protocol, I think the expectations of ourselves for what we can do for our patients is increased. So clearly there is a survival impact of risk stratification, but it is still not as we would expect in contemporary practice in high-income countries. And what you can see is the relapse rates are again higher by risk groups. So about 1/6 of patients with standard risk ALL experience relapses. Remember, this is from the observational study because the follow-up is more mature. 1 out of 5 patients with intermediate risk experience relapse, whereas 1/4 of patients with HR and TALL experience relapse. Looking at the relapse a bit more closely between the observational and randomized trial, what you can see is that if you look at the top, relapse is 25% versus 19%. It looks as if it is fewer relapses, but actually the follow-up is shorter in the randomized trial, by 18 months. So it's I think one cannot take comfort from this. Relapse, soberingly, the bulk of the relapses are actually about 75% of relapses occurring very early, which is on treatment within 18 months of diagnosis, or early. That means more than 18 months, but less than 6 months from end of treatment. Bulk of the relapses, 75% of the relapses, are actually bone marrow relapses or combined, either isolated or combined. If you look below in the lowest, what you can see is that for, high-risk patients contribute to about 50% of relapses, but non-high-risk patients, that is intermediate risk and standard risk, contribute to about close to also about 50%. So that is sobering. And the other important point is that we also seem to have an isolated extramedullary relapse about 5 percentage points higher than what is reported by other groups. And we seem to have, especially in certain centers, a higher proportion of testicular relapses, not very commonly reported in high-income country protocols. So looking at the remission rates, there are some hurdles for us to address. And that comes soberingly from the impact of MRD. Remember, we said that we will use genetics and MRD to identify a group of patients who can have de-intensified therapy. And clearly, if you look at the top, look at the arrow, you can see that when you look at all patients, MRD is patients with low MRD, end of induction, 20% have relapsed compared to about 10 percentage points higher in patients with high risk, high levels of MRD. So MRD seems to be, so relapses are fewer in patients with low end of induction MRD, and that is very significant data, but that effect is mainly seen in patients with intermediate risk disease. So if you look in the lower arrow, you can see that 19% of patients with low MRD and intermediate risk disease had relapses compared to nearly double that. Whereas in standard risk patients, MRD was not really predictive of relapse. And that is different from what has been reported in the developed world protocols. So MRD in our hands is not yet predictive of relapse in the non-high-risk patients. So there is still work to be done as far as MRD is concerned. The second important point is genetics. And what you can see on the left-hand side is remember we said we identify only high-risk genetics and treat them as high risk. For the non-high-risk genetics, there is no it's based on patient characteristics and treatment response. But what you can see on your right-hand side in the survival curve is that there is a group which is in lavender color of B other ALL patients who are neither the good risk group, which is ETV61X1 high hyperdiploidy, or in the high risk group. And if you draw your attention to the left-hand side, you can see that these patients have unfavorable characteristics and poorer treatment response. So the genetic risk stratification, perhaps this group also needs to have a targeted strategy. So we need to do better as far as risk stratifications is concerned. The other important problem is drug treatment. Many of you may be familiar with this. This is the work from the Tata Memorial Hospital in Mumbai, reported about 4 to 5 years ago, showing that native E. coli asparaginase biogenerics have poor activity. So if you look at this here, you've seen G1 to G9 represent various brands of biogenerics. On the y-axis, the proportion with adequate activity, and you compare to the innovator, which is the Kyowa Hakko product from Japan, you can see that the levels of proportion with adequate activity is actually poorer. So even our drug, there is a problem with our drugs as well. In parallel, while we are addressing these hurdles, we have not rested and we've continued to move ahead. And two things, one is wider implementation and second is treatment refinement. So if you draw your attention to the left-hand side of the India map, what you can see is that the 5 centers which were in the 4 parts of the country, north, south, east, and west, have now partnered with spoke centers. These spoke centers are 21 centers which are partnering the initial icicle group centers. So there are 21 plus 5, 26 centers coming together to implement the non-randomized icicle ALL protocol and introducing not just from diagnosis, treatment, and monitoring. In parallel, the hub centers are moving on to a successor randomized trial and also testing additional randomizations to decrease, to improve remission rates, which is the pulse dexamethasone in induction, and also escalating Kaposi methotrexate. And the reason for doing that is because now with a better asparaginase, with access to better asparaginases, these methotrexate asparaginase combinations can be now provided to patients. And that is highlighted in this particular slide. This is work again from Tata Memorial Hospital, Mumbai. We now have access to biogenerics, which is, just draw your attention to the left-hand side. This is a pharmacokinetic profile. On the y-axis, time from drug administration. On the x-axis, time from drug administration. On the y-axis is asparaginase activity levels. And you can see that the profile of both the reference drug, which is in red, and the test drug, which is in blue, the biogeneric drug, are similar, and there is numerical data corroborating the same. So we now have access to good quality, or at least equivalent quality biogenerics. So I'm now ready to wrap up, just to say that we are now to address poorer outcomes in our patients. We had to develop a uniform, contemporary risk-stratified treatment protocol, collaboration, standardized diagnostics, and randomized interventions which are tailored to our local priorities. The immediate impact of this initiative was lowering treatment-related death. The impact on remission rates is less pronounced, and that may be because of some systemic hurdles that we need to overcome. And these are represented here cheekily as 4Ds: diagnostics, drugs, disease management, for instance, in areas such as thiopurine and ALL maintenance, or intrathecal methotrexate, how it is administered, and also better data capture, especially finer toxicity information. And while we're doing this, the effectiveness of a protocol is only how well it is adopted, and therefore we're continuing to implement in a wider group and refine as well, including focusing on defined risk groups such as children with Down syndrome, etc. So now left for me to thank people, patients and families who have placed their trust in us and followed our and participated in these studies, the Trials Network, and the various investigators, the Indian Pediatric Hematology Oncology Group, of which we are a part. These are and the funding agencies that have supported us. I just want to highlight two people, key people here on the right-hand side. The lead, Dr. Nandana Das, and my colleague and partner in crime, Mr. Parag Das, who's the analyst on the clinical research unit, and all my colleagues and investigators, starting with my mentor and tormentor on the extreme upper left, which is Dr. Vaska Saha, along with Dr. Shripad Banavali, whose discussions germinated this idea, and then the many investigators, senior and less senior, who are part of this initiative, and the lab leads who have provided the inspiration and the drive to standardize the diagnosis. With that, I end my talk. Thank you very much for your attention.
Yeah, no, thank you.
Thank you, Dr. Krishnan. Now we have a very short question and answer session. Most of the questions for the previous talk have been answered by Dr. Amita Mahajan directly. So I would request Dr. Caesar to take up the questions from the Q&A.
Thank you, Anita. So, one of the questions for Dr. Krishnan, given the DI, what is the rationale to give the DI to all the groups?
The question is, why do we have a uniform delayed intensification protocol for all patients?
Yes.
Yes, I think that's the question for one of the participants.
Okay, so most study groups have actually, so as we know, that I mean, I'm unable to answer this question directly. Sorry.
Hey, please proceed. Yeah.
Yeah. So as we know, DI is a delayed intensification is actually a hybrid of typically a hybrid of both the induction and consolidation phases. And groups have tested either, and therefore that is considered to be a fairly standard block of treatment. Therefore, we have not modified it in any way. Groups have tested 1 versus 2 delayed intensification protocols and found that actually a single delayed intensification block is sufficient. Historically, groups that have dropped delayed intensification or modified elements of it, for instance, changed the steroids or dropped the asparaginase or eliminated the intrathecal treatments, have shown poorer outcomes, and therefore we stuck with what has been practiced. It's a very good question because there are groups now in Malaysia and Singapore, for instance, who have reported trying to attempt dropping anthracycline in delayed intensification. This has also been tested by the BFM groups. These may come in our successor protocols, but that's so we initially used what we knew, and these refinements may follow that new course. So that is my answer to the question.
Thank you. The other question of one of the participants is questioning about the steroids window in patients that they have high white blood cells or mediastinal masses.
Yeah, thank you for the question. I think I think my interpretation is, how do we manage the steroids in patients with high presentation white count? I just wanted to talk 2 points. One is the prednisolone prephase allows us to provide to stabilize patients who come to us at first contact. And what we do initially is that we start a calibrated steroid escalation in these patients, starting with a lower dose and escalate based on tumor lysis parameter monitoring. This is more a physician-directed plan, but we start with lower dose and then escalate. So that's what we do. And then very, very quickly, normally by day 3 of treatment, we are able to go to full dose of steroids with very little problem. And now with the access to raspuricase as well in patients with very bulky disease or high uric acid, TALL, this is not so much of a challenge in our experience, provided G6PD activity is sufficient.
Okay, I have a question for you, Dr. Krishnan. In one of your slides, you mentioned about the MRD division between low and high, and there's some difference in terms of response. Knowing, as you put it, that the minimal residual disease was less than 0.01 on day 35, what is the meaning of low? I am trying to understand if this is positive but less than 0.01, or there is another meaning for you guys.
Yeah, thank you for the question. So what I've understood is what is the cutoff for categorizing somebody as low and high? Have I captured the question correctly?
Yes, for minimal residual disease, because based on that, you made some assumptions from the protocol.
That's correct. That's correct. So we used the single time point minimal residual disease at end of induction was used to stratify patients. We used initially when we started, we used 0.1%, which is 1 in 1,000 cells. But then later, very quickly, the labs became quite competent, quite capable and comfortable assessing 1 in 10,000, and we moved to 1 in 10,000, which is 0.01%. Patients with 0.01% or higher were stratified as high risk. Patients with lower than that were stratified as non-high risk patients. As we learn over the protocol, we have now become a bit more stringent. We have increased our event capture over the course of the clinical trial and beyond, post-trial as well. Initially starting from 1 million events to at least 2 million events. And now there is, at least in our center, and I'm certain increasingly in other centers as well, any detectable MRD is being used to stratify patients as high risk, rather than using a strict cutoff of 0.01%. But this is a matter for, I have not discussed this, because this may cause some confusion in the minds, because this is a matter for the successor trial. But for the clinical trial that I presented, we used a hard cutoff of 0.01% to stratify high. I think that's the question you asked. I hope I have addressed that.
Okay, thank you. A general comment, I know, and I have advocated, and I think that you mentioned on Dr. Mahajan too, is the treatment-related mortality, and I think the toxicity induced for medications is important, particularly for what you mentioned in the ALL protocol during induction time, which is quite high. So I think that doing a little more aggressive intensive care is going to be useful. But the other question is going to be for both of you, and I think that is common for the different participants, is about your case would be the use perhaps blina or inotuzumab. In Dr. Mahajan case, most likely going to be the use of brentuximab plus PD-L1 inhibitors. So I would like to get both of your opinion about the use of this, and I think that the participants are interested too.
So thank you, Sita, for that question. And immunotherapy has, it continues to be very expensive, and so does brentuximab. But brentuximab is actually too, very expensive for us. And now with this data on nivolumab, so we in India, most of our colleagues, we don't have much experience with pembrolizumab, but because nivolumab is used for multiple indications in adult oncology, the cost is much, much lower in our country, and based on some limited adult data with much lower doses. The combination that many of our colleagues and even at our center that we are using is a very low toxic or low toxicity protocol of bendamustine with nivolumab. And at a dose not at 3 mg per kg, which is the recommended dose, but a standard dose of 40 mg. But even with this, and it's only a bridge to take a patient to transplant. So that is the protocol, and that's why we were very interested, because when I attended the recent International Hodgkin Lymphoma protocol, they were very interested to see our data with this dosage as to where we are. We are in the process of collecting retrospective data over the last 5 years when the use has really increased in our country as to what have been the response rates, what are the settings, what are the toxicities, but also in a way to look at it prospectively, because that combination becomes cost effective to us than more intensive chemotherapy protocols because of the additional costs that we incur to manage the treatment related toxicity. So, but it is definitely what we've seen, it is useful to help us to take the patient to stem cell transplant. Whether it will work for us even in that, as you could see that most patients did not have access to it, but our study was done in COVID times. Access to intensive modalities of treatment is increasing with, a lot of public-private partnerships and a lot of other initiatives. So this is an area that I think we will have to answer for ourselves as to what is the best protocol for us for relapsed refractory setting. And also probably have more than one choice or one standard of care. And I think we actually could answer this for many other low middle income countries.
Dr. Krishnan,
I have to plead not this area. So I think I'll defer to Dr. Amita on this point. So I don't have any additional comments to add.
Okay. I think that it's very interesting the use of immunotherapy. Recently, the COG, in combination with the SWOP, we did a study in comparing chemotherapy versus bevacizumab versus chemotherapy with nivolumab. And the arm that was with nivolumab produced better results overall than the bevacizumab, and both of them, they are better than the ABVD that has been used previously in the adults. I think that would be useful. And also the addition of monoclonal antibodies like unitumumab. I know that the price is an issue. Definitely has improved, particularly in the relapse setting, the event-free survival and overall survival. I had a question to the rest of the panelists. There are several other questions here, but I don't know in terms of the timing, how are we doing? Anita, Susan, what do you think?
I think we can take one quick question and then finish, because we're already 10 minutes late, Asisa.
Yeah. I think that there are several questions. Just for the general comment, there are questions about treatment-related mortality. It can be omitted and anthracycline. The testicular involvement as a high risk can be benefit or no. There is another question about the use of pharmacogenomics. And one of the things that we are trying, and this is a general overview for the group, one of the things that we are trying with Anita, with the SIOP leadership, is using this particular platform of the partnership group to set up a specific disease-oriented pipelines. So, and I think that lymphomas, leukemias, I think that there are two of the major pipelines that we can use later on. And the idea is to try to make sure that groups from different continents, they can come together to create one disease-oriented pathway. So that's a little bit of housekeeping. But I think that probably one of the questions will be, can we reduce the anthracycline in the identification?
Shall I take that question? Yeah. So thanks, Dr. Cesar. We have, it's true. So one of the things that we have noticed is that, so one of the things we think we would like to do similarly is more than pharmacogenomics for anthracycline. I think what we want to do is try to limit the exposure of patients to anthracycline. Now that we have access to at least quality assured or therapeutically active asparaginases, especially in patients with what we believe is low risk disease. So I don't have any specific comment about anthracycline-related pharmacogenomics as a tool to spare patients from toxicity. I have one additional comment, like a lateral comment, and is that for us, we think that the polymorphisms related to thyroid metabolism in ALL maintenance, I think are important for us to evaluate, and also perhaps a G6PD status, especially when it comes to both when handling cotrimoxazole and anthracyclines and perhaps raspberry cases.
Okay, thank you, Dr. Krishnan. Just to remind again, I think that it's important to keep in mind that the different disease-oriented pathways that we are trying to create, and I think that it's important participation in that as well, generally in SIOP. Nita, do you want to close the meeting? By the way, there were 98 participants. Thank you very much.
Yes, so that was indeed a really good participation, and thank you to both our speakers. Wonderful discussion on how indigenous protocols have helped and how data collection. I think the very fact that both of you reported that while on a protocol, abandonment rates came down, that is really heartening to hear. And that's again highlights the importance of patients being on research protocols so that it helps even improve the standard of care. The documentation improves, and that's all. I think we've all seen that as well in our centers also. So I thank Dr. Amita Mahajan and Dr. Shekhar Krishnan for taking out time from their busy schedules to discuss this work and to highlight these two projects from India to the rest of the world. I thank the SIOP admin and the SIOP for initiating this spotlight activity to highlight national pediatric hematology oncology groups. And Tessie and Susan and Nancy and everyone who's been working really hard to get this program on board and to get everything smoothly, as in streamline everything for us. And I thank Guillermo and Regin, the current the SIOP leadership, the SIOP Global Health leadership as well, for helping us work out this program to define the terms of reference of the SIOP Partnerships Working Group and to add this as a new initiative from the SIOP Partnerships Working Group. And finally, to my partner in crime, Caesar, thank you for, over the last 2 years, I think we have had our fair share of programs, and this, I think, is a very good initiative which will help build partnerships between countries and even in the same country between centers. And thank you for this. Thank you for joining us today. And we'll be back soon again with the next edition of the Spotlight with another country's program and another research from another country. Thank you on behalf of Caesar and me. Thank you to all of you for joining us today.
Thank you for the opportunity. Thank you.
Thank you.
Thank you very much.
Thank you, guys.